And our first speaker, Dr. Kathryn Ruddy, is a professor of oncology with a specialty in male breast cancer and consultant for the Division of Medical Oncology at the Mayo Clinic in Rochester. So welcome, Dr. Ruddy.
Thank you so much. It's really a pleasure to be here with you all, and I'm honored to be the first speaker for this terrific event. I'll be talking today about living well during and after male breast cancer treatment, and hopefully I'll leave time for discussion at the end. I'd love to hear thoughts from the group and learn from you all as well. I don't have any conflicts of interest, and I thought I would just touch briefly on male breast cancer epidemiology, since this is the first talk of the day. Just talk a little bit about clinical and biological features of male breast cancer and prognosis, as well as a bit on treatments. I know there'll be more on that later in the day. I'm going to focus most of what I'm talking about on survivorship recommendations and symptom management. As you know, there are about 2,000 cases per year, actually a little bit more than that now, of male breast cancer diagnosed newly in the United States. And this incidence is rising. It's still only a little less than 1% of all breast cancers in the US that are diagnosed in men, but it is a very important problem, and actually more common than some of the other cancers that have received a lot more attention and more research funding. And so I think probably everyone on this call can agree that we need more research and attention to male breast cancer to move the needle in terms of our treatments and to help men live well during and after cancer. There are some other countries where male breast cancer is significantly more common than it is in the United States, and that seems to track somewhat with liver infections, which endemically in certain parts of Africa lead to hormonal imbalances, and then that is probably part of why we see higher rates of male breast cancer there. There are also, on the flip side, a lower numbers of female breast cancers in some of those areas, so the proportion of cancers that are happening in men are higher. From a clinical and biological feature standpoint, most breast cancers in men present as a hard, non-tender mass. On average, these cancers have grown to about 3 centimeters by the time of diagnosis. And that's because obviously we don't have routine screening mammography in men. So these are larger in general than the cancers that are on average diagnosed in women. Nearly half of all men do have nipple changes at the time of diagnosis. These cancers do tend to be near the nipple, and about 40% of men have enlarged lymph nodes at the time of diagnosis as well. The average age of diagnosis for breast cancer in men is 67 years old, which is older than in women, and in part that's probably due to the lack of screening tests in men not finding these earlier. And one of the biggest differences between male breast cancer and female breast cancer is that a much larger proportion of male breast cancers are hormonally sensitive. So when we talk about the estrogen receptor being positive on a breast cancer, that means that the cancer does respond to hormones, and sometimes often is treated with anti-estrogen treatments. And this is much more likely in men than in women, and we don't really understand why that is. Happily, when you match breast cancers by age and stage, meaning how big the cancer is and whether it's spread to lymph nodes, men do not do any worse than women. In fact, some studies suggest men may have slightly better prognoses than women. And outcomes are improving. And we know that younger men and those whose cancers have not spread to lymph nodes do even better. Unfortunately, we have never successfully had a large treatment trial in men. And I know Dr. Leon is coming after me and will be talking about his very exciting newly launched Ethan trial. And we're really hoping this changes this. And the next time, or at least within a few years, we can talk about male breast cancer and talk about the results of his trial. But for now, we're extrapolating our treatment decisions from data that have been gathered largely from women. Oncotype DX is a very important tool as a breast medical oncologist that I use daily in my clinic to help understand if a patient will benefit from chemotherapy. And we know that when the Oncotype DX scores, which are basically derived from a 21 gene assay that is run on a tumor specimen in order to understand prognosis and chemotherapy sensitivity, we know that those scores are approximately the same in men as in women, but we haven't had a large study to validate the use of this I still do use this test because it's so important. If we did not use it, men's decision making would be very impaired with regard to whether or not they should receive chemotherapy in some situations. So I think my colleagues and I have extrapolated from data in women and do use this test in many instances. There was a prior trial that tried to assess what is the best anti-estrogen treatment for men, but unfortunately no one enrolled and it was closed early. That was many years ago. So I think Dr. Leon's Ethan trial will hopefully be much more successful and already has been. In terms of what do we do, what does the American Society of Clinical Oncology, which is our largest oncology society in the United States, and in fact has a presence internationally, and is well respected for guideline development for cancers of all sorts. What does ASCO tell us we should do as treatment for male breast cancer? First, ASCO does recommend tamoxifen, which is an estrogen receptor blocker, for at least 5 years for men who have early stage disease, meaning cancer that has not spread to other parts of the body, cancer that's either just in the breast or has perhaps spread to regional lymph nodes in the chest, but not to other parts of the body. Tamoxifen for 5 years is recommended. And for men who have had their cancer spread to other parts of the body, also endocrine therapy, meaning some type of anti-estrogen, and that usually is tamoxifen. It would still be the first treatment. In that situation, we end up often using multiple sequential types of treatment to manage a cancer over a long period. And one interesting piece of this guideline from ASCO is that while we use bone modifying agents, meaning osteoporosis medicines, you all may have heard of medicines like Zometa, which is a osteoporosis medicine that's been around for a long time. We often use those in women because there's some data to suggest that these prevent recurrence, particularly in postmenopausal women. ASCO recommends strongly against using these to prevent recurrence in men because we really don't have any data for that. But we can use these for bone health. So if men are experiencing osteoporosis, we can treat with these agents. Turning to endocrine therapy, because this is such a mainstay of treatment for men with breast cancer, and that's in part because of these very strongly hormonally sensitive cancers. Endocrine really means that we're affecting the hormones. Usually this means we're either blocking the estrogen receptor or we're reducing the amount of circulating estrogen in the body. We use these in women with breast cancer if they have hormonally sensitive cancers, and we use them in almost all men with breast cancer because greater than 90% of male breast cancers are hormonally sensitive. There was a case series quite a few years ago now, we're nearly 20 years ago. Dr. Giordano, who is a male breast cancer expert in Texas, assessed 135 men who had over 14 years of follow-up and showed that those who received the endocrine therapy did do better than those who did not. So that was, in female breast cancer, we have studies of thousands and thousands of women to prove this. In male breast cancer, we have small studies, but this has been turned to as an important reason why we should give anti-estrogen treatment to men. Tamoxifen, as I said, is the gold standard for male breast cancer. We do have other potential options, and Dr. Leon will be talking about his Ethan trial, which is trying to ascertain whether there is anything better than tamoxifen for treatment of male breast cancer. So I won't go into that in greater detail. He'll be speaking next. We do sometimes also give chemotherapy, and that is particularly considered for men who are younger and therefore would have fewer other medical problems that might make chemotherapy dangerous. For those who have higher tumor grade, meaning that if the cancer is dividing more quickly, it tends to be more sensitive to chemotherapy. And also for those who have either a larger cancer or whose cancer has spread to the lymph nodes, we'll be thinking whether or not we should use chemotherapy. Because men do have more hormonally sensitive cancers, these hormonally sensitive cancers often are actually a little bit slower growing and therefore may be less sensitive to chemotherapy. So the proportion of men who get chemotherapy is a little lower than that of women because women on average may have less hormonal sensitivity and more rapidly dividing tumors.
Thank you.
So turning to cancer survivorship more broadly, I love this quote by Fitzhugh Mullen. He was a physician who published in the New England Journal of Medicine, which is one of our most respected journals in the world. He published now approximately 40 years ago as a cancer survivor himself. and said the challenge in overcoming cancer is not only to find therapies that will prevent or arrest the disease quickly, but also to map the middle ground of survivorship and minimize medical and social hazards. And this is really the passion of my life, is to try to optimize quality of life and minimize the symptoms that people are experiencing both during and after cancer therapy. And that means that we have to be paying attention both to, on the right of the slide, you do see some of the psychosocial concerns. So some of the really important psychological and social sequelae of cancer can include fear of recurrence, depression, anxiety, financial burden. We have really an understanding that cancer treatment can place extreme financial burdens on people due to the treatments, due to lost employment, due to all sorts of pieces of the cancer journey that can be incredibly problematic. We also know that we need to be paying attention to families, caregivers. We need to be talking to people. I, as an oncologist, always want to make sure that my patients are aware that genetic testing may be of value both to them and their families. And especially just with regard to male breast cancer patients really should all be visiting with a genetic counselor to consider genetic testing, because there is a 10% rate of a deleterious genetic mutation in men who do have breast cancer. And I know there'll be a talk on this later today as well, so I won't go into greater detail except to say that counseling is very important. In the middle of this slide, you see some of the medical issues that can come up after a cancer diagnosis. Even after treatment for male breast cancer is completed, there is need for surveillance to both look for any recurrent disease, but also to look for new primary cancers, complications of cancer therapy, and lifestyle counseling is also very important. Exercise and healthy lifestyle can improve quality of life and can be very important in breast cancer survivorship. And then going to the left, I'm sorry, I'm reading this slide in kind of an unusual order from right to left. On the left, you see that there are non-cancer related medical issues, including disease prevention and other medical problems that a patient may have, like diabetes, even before the time of diagnosis, but then can be sometimes ignored during a cancer treatment period and really do need to be attended to both during and after cancer therapy. And doing all of this well requires that primary care providers, oncologists, and other providers work together. I mentioned germline genetic testing. It really is important, both because if you have a male breast cancer, you do have approximately a 10% rate of carrying specifically a BRCA2 mutation, but also other mutations. We know that BRCA2 is not only associated with male breast cancer, but also with other cancers, including prostate cancer, pancreatic cancer, gallbladder and bile duct cancer, gastric cancer, malignant melanoma. So it's important to figure out if you, as a male breast cancer patient, do carry a BRCA2 mutation, so that family members can be tested, but also so that you can discuss whether additional screening for other cancers is needed. With regard to heart health, for those who receive a chemotherapy regimen that includes doxorubicin or another anthracycline chemotherapy, we do have a recommendation that an ultrasound of the heart, or echocardiogram, be performed 6 to 12 months after the end of that chemotherapy. And that's because we know that this type of chemotherapy can cause heart problems. And if there were an abnormality found at that echocardiogram, more help from a cardiovascular standpoint would be needed. Sometimes medications are needed to optimize cardiac health in that situation. And in addition, routine age-appropriate screening for other medical problems like high cholesterol, high blood pressure, and other cancers is certainly warranted. The United States Preventative Services Task Force guidelines are listed here, and I wanted to show these because I think it's actually sometimes very difficult to get in to see a primary care provider, and I think we do have some inadequacy of screening for some of these things because of that. With COVID especially, sometimes it was difficult and primary care provider care became less frequent. So just to quickly run through so that people are aware, we all as adults in the United States are recommended to have blood pressure and weight measurement. The frequency of this is somewhat controversial, but annually has been suggested. Fasting plasma glucose. So this is looking for diabetes when we all do need diabetes screening about every 3 years if we haven't been previously diagnosed with diabetes. If we have been diagnosed with diabetes, obviously more frequently is needed. And then cholesterol testing for those aged 40 to 70 is recommended every 5 years. And for those with higher risk of abnormal cholesterol based on family history or other concerns may need cholesterol testing to start sooner than age 40. And then, of course, anyone who is smoking does deserve counseling to help support smoking cessation if possible. With regard to cancer screening, this same group recommends colon cancer screening from ages 45 to 75, or a consideration of colon cancer screening up to age 85. And that could be colonoscopy or other tests. There are a variety of tests now available for colon cancer screening. Lung cancer screening is also now part of the USPSTF guidelines, and that's recommended for those who are 50 to 80 years old who have a 20+ pack year smoking history, either ongoing smoking history or within the past 15 years. And that what's recommended there is an annual low-dose CAT scan. I know there'll be a talk later today talking about imaging recommendations for male breast cancer survivors. I'll just briefly say that ASCO does recommend annual mammograms if a man has had a lumpectomy of that same breast. ASCO only recommends an annual mammogram of the opposite breast if there is a high-risk genetic mutation like the BRCA2 mutation, and ASCO recommends against breast MRI during follow-up. We have a different organization, the National Comprehensive Cancer Network, which also puts out really terrific guidelines. Some of these are even more well directed to patients. They have materials that if you haven't looked at, you may want to go to the NCCN website. It's nccn.org, and anyone can have access as long as you have an email address. One of the pieces of the survivorship guideline for cancer survivors is a very detailed recommendation for exercise, including not just the 150 minutes of weekly activity that I often recommend to my patients in clinic, but also 2 to 3 sessions per week of strength and resistance training, stretching, and then general physical activity daily, including avoiding prolonged sedentary behavior, movement breaks, standing and walking as much as possible. So why are these, what could exercise possibly help with? There are a variety of different side effects of breast cancer therapy. These can relate to local therapies, so surgery and radiation can cause problems like lymphedema, the swelling of the arm and the side where the surgery or radiation was administered. Systemic therapy, systemic I mean medicines that either are administered by mouth or intravenously that are entering the bloodstream. It can then cause side effects including osteoporosis, which is bone thinning, hot flashes, muscle and joint aches, trouble sleeping, nerve problems, infertility, and blood clots. And then both the local therapies and the systemic therapies can cause problems with the heart, pain, emotional distress, weight gain, fatigue, and other cancers. And so these are all important things to think about for me as I'm trying to both help my patients in clinic and also consider what research needs to be done to be able to help male breast cancer patients and survivors feel as well as possible. There have been a few studies that have looked at the side effects of tamoxifen and other anti-estrogens in men. This one was published now 30 years ago and showed that nearly a quarter of a small group of men taking tamoxifen actually stopped taking it within a year, and that was largely due to side effects, including decrease in libido, weight gain, hot flashes, problems with sleep, and there was one man with a blood clot. Another similar study, a little bit more recently, assessed men taking both tamoxifen and other anti-estrogen medicines, and again, about half of men did experience and report a side effect, and approximately a quarter stopped early due to side effects. And so that's really important because if the side effects of these medicines are so severe, they not only impair quality of life, but also impair men's ability to continue to take these medicines and to treat their breast cancers. And a third study, similarly, another here, a slightly larger, 64 men who are taking tamoxifen, approximately half had a side effect, And these were, again, weight gain, sexual problems, and then a smaller numbers with eye problems, leg cramps, thinking issues, bone pain, and other issues. Dr. Schroeder speaking later today. She published a very important paper I think she may be talking about later today, so I'll only show one slide from this paper from last year. This was a study in which we enrolled men through a very large international consortium led by Fatima Cardoso, and in the United States, our Translational Breast Cancer Research Consortium, TBCRC, was involved. We were able to survey men close to the time of a male breast cancer diagnosis and ask about a variety of different symptoms as well as quality of life. And what I'm showing you here on this graph is that men with breast cancer are depicted by the green bars on this graph. Men without breast cancer, their symptoms are depicted by the blue, and women with breast cancer, their symptoms are depicted by the pink. And so you see the score here would indicate worse symptoms actually in women with breast cancer than in men with breast cancer close to the time of a breast cancer diagnosis. And you're seeing the symptoms that are listed here are fatigue, nausea, pain, difficulty breathing, sleep problems, appetite loss, constipation, diarrhea, and financial difficulties. But what we don't know yet, and what we're very much wanting to assess and will assess as part of this study, is how this might change over time. So this was close to the time of diagnosis. Our next analysis will be looking at 1 year, how did survey results potentially change, and were there certain symptoms that men started to really have more difficulty with? And I would also say that even if men are not reporting as many symptoms as women with breast cancer, that doesn't mean that they're not reporting symptoms. There are still significant symptom burden that's indicated by these results. So how can we help mitigate some of these symptoms? One very common issue that we have seen in these surveys that I hear from men in my clinics is that hot flashes can be extremely problematic, and I think can at times be really even more difficult for men than women. And that is in part perhaps because men don't have others in their communities who don't have cancer who are experiencing this. Now, men with prostate cancer do experience quite a bit of hot flash burden as well. And so there have been some studies that have assessed hot flash treatments in men with prostate cancer. That said, we must extrapolate for men with breast cancer from both the prostate cancer literature as well as from literature in women with breast cancer. And we know that there are options for treatment, including some antidepressants, gabapentin, oxybutynin, which was just actually published to be effective in men with prostate cancer, as well as from a behavioral standpoint, cognitive behavioral therapy, hypnosis, and possibly weight loss. The antidepressants that we sometimes consider for hot flash therapy are the top paroxetine, citalopram, escitalopram, venlafaxine, and desvenlafaxine. And here are some doses. If you are struggling with hot flashes, please do discuss with your doctor whether some of these would be appropriate for you or whether one of these would be appropriate for you. In terms of practical tips for hot flash management, keeping the bedroom cool because hot flashes do commonly occur at night and can interrupt sleep, dressing in layers, using a fan, and then the neck tends to be a trigger zone for hot flashes. So keeping the neck cool with a cool pillow or washcloth can be very helpful. Sleep problems, I think, are almost universal these days for a variety of reasons, but certainly anti-estrogen treatment for breast cancer can make this worse. And certainly good sleep hygiene is critical. We're all tempted often to have devices in the bedroom, which then we look at when we wake up in the middle of the night. That is obviously can be very problematic for sleep. And cognitive things like pets in the bed, snorers in the bed can obviously also be a bit problematic and can be sometimes more difficult than getting the devices out of the bedroom. Cognitive behavioral therapy may help with sleep if insomnia is persisting despite treatment of hot flashes. And there are other symptom management strategies that we also have data to support. For those who do experience after chemotherapy, numbness and tingling of the hands and feet, we do know that duloxetine is a medication that can help with this. For those who have joint aches from breast cancer treatment. Exercise, acupuncture, and duloxetine all are effective strategies. And for those who have swelling in the arm related to surgery or lymph node radiation, compression therapy and physical therapy can be beneficial. I'm going to talk just briefly about a couple of other treatments that are just recently shown to be effective. For people who have to receive capecitabine chemotherapy, which is an oral chemotherapy that we sometimes give both in the metastatic setting and also now sometimes in the early stage setting to those whose cancers do not totally go away with preoperative chemotherapy, we sometimes consider postoperative capecitabine. This medicine traditionally has a high rate of causing something called hand-foot syndrome, which means that the hands and the feet can get red and painful. And here we now have data to show that a very inexpensive and quite easy to apply diclofenac gel, which is Voltaren that can be bought at any pharmacy over the counter. If patients apply that twice a day as they're starting their capecitabine pill, we significantly reduce the amount of hand-foot syndrome that is seen. And at the bottom of this table, you'll see grade 1, grade 2, grade 3, and those are the rates of first in the first column, those who are using the diclofenac gel, very low rates of the hand-foot syndrome, and higher rates in those who were using the placebo gel. So we're now, this has now come into our practice as a standard symptom management mitigation strategy. Immunotherapy is also huge, really, across oncology, and I just wanted to mention it briefly, not that it is a common treatment for men with breast cancer, because men are less likely to have the type of breast cancer, generally triple-negative breast cancer is where we're using these immunotherapy drugs. So triple-negative meaning it's hormonally insensitive. That's very rare in men. But if a man does have a triple-negative breast cancer, he may receive immunotherapy. And immunotherapy really means that these are medications that upregulate the immune system. They use a person's own immune system to fight the cancer, which is an exciting strategy that's been proven effective across a wide variety of cancers, but it does have side effects. And so it's also important to note that people who are receiving immunotherapy have high rates of reactions to the infusions, rash, a permanent thyroid dysfunction, and as well as a lung inflammation or pneumonitis. I want to finish by just talking briefly about the fact that we do need more research in male breast cancer. This pilot study, which we conducted many years ago now, attempted to, well, we did partner with 3 male breast cancer organizations to try to understand the experience of men with breast cancer during their survivorship period. Our average age of participation was approximately the same as the average age of diagnosis across the U.S. Men were nearly 2 years after diagnosis on average, and they were were slightly more well off in terms of financial status than the average male breast cancer patient. 74% were married or living as married, and 98% were white. So I don't think these experiences reflect the more diverse population that does experience male breast cancer. That said, it was important to note that now we published this more than 10 years ago, but not all men were being referred for genetic counseling at that time. 74% reported that they had been, 60% had had genetic testing, and 12% were found to carry a BRCA2 mutation. So I think hopefully these numbers have improved. Since then, we really ideally should be getting close to 100% of men at least being referred for genetic counseling so that they can get the information they need about whether this is something that they want to pursue. We asked men also about fertility concerns because our breast cancer treatments, any cancer treatment can have impact on fertility. Many of the men in our survey, not surprisingly, with an average age of 64, had completed their desired family size at the time of this survey, and a small proportion had stored sperm prior to treatment, 2%. the symptoms that men reported on this survey included a relatively hefty 31% who were experiencing ongoing numbness and tingling from their chemotherapy, presumably. Approximately 1 in 5 were experiencing chest wall pain, and almost 1 in 5 lymphedema, and then a very concerning but low rate of cardiac toxicity or heart problem that was attributed to the breast cancer treatment, and presumably this was the anthracycline chemotherapy. So just to wrap up, I think there are quite a few remaining questions in male breast cancer care, and I hope we can launch research that will help us understand specifically what we can do to improve symptoms in male breast cancer survivors. I'd also love to be able to better counsel my patients on whether chemotherapy benefits are the same in men, and whether lifestyle data in women, we know, for example, that exercise, minimizing alcohol, losing weight are helpful for reducing risk of breast cancer recurrence. I don't know that in men, and I would love to understand that better. And also lymphedema management, we extrapolate from studies in women. Dr. Leon will be speaking next on his very, very important work to understand what the best endocrine therapy is for men. And so I am optimistic that this final question we will have the answer to in the near future. Thank you so much for your attention, and I'll stop and take questions.
Thank you, Dr. Ruddy. I actually have 2 questions in the chat first, if we
Oh,
can.
good. Okay.
One of them is, are there any trends in screening, clinical trials, and treatment for breast cancer in men that you have observed across the different regions of the world? Are there any that you know of?
So, sorry, did you say screening?
Screening, clinical trials, and treatment for breast cancer in men. So
from a clinical trial standpoint, the only clinical trial I'm aware of is the one that Dr. Leon is about to present. That's the Ethan trial we do have open now in the US, and we're really excited to be able to enroll, and that has already started enrolling. I'm not aware of any clinical trials elsewhere in the world, although there could be. The international collaboration that I mentioned that Dr. Schroeder published, the baseline quality of life data from last year, has been really trying to get an international trial off the ground. What's particularly challenging with this is that funding a trial that crosses countries without industry sponsor is extremely difficult, because even if we could get a grant from the NCI to fund our US portion, that would not fund the portions in other parts of the world. So we have thought about that. It would be extremely helpful to be able to launch a trial like that, but we've not been able to figure out how to fund it. And then with regard to screening, male breast cancer really has not been something that screening has been proven to help with. So there is no routine screening for male breast cancer. Most male breast cancers are diagnosed when a man either identifies his own breast abnormality, or sometimes a partner, or sometimes a doctor identifies this. But it's not, I'm not aware of in any parts of the world any screening efforts for male breast cancer.
Okay, the next one is furosemide, I hope I'm pronouncing that correctly, an acceptable choice with tamoxifen? Had very heavy legs after starting tamoxifen, and they have me taking furosemide twice a week. It helps, but I'm curious.
Yeah, I've never heard of any interaction between furosemide, which is a diuretic. It kind of helps your body get rid of extra fluid, and tamoxifen. I think that should be fine. We do have quite a few patients who have leg cramping on tamoxifen, and it doesn't sound like that's what you're experiencing. So I think if furosemide helps with your symptom, then that would be fine to do. If you've received a prior chemotherapy like doxorubicin that could impact the heart, you should certainly do an ultrasound of the heart also to make sure that's not part of what could be causing the heaviness in the legs. But in terms of tamoxifen and furosemide, I don't see any problem with that, to my knowledge.
And I have one other one. Are you aware of any guidance for men with the PMS2 Lynch syndrome and family history of breast cancer, BRCA negative? Also, is only 12% had a genetic If only 12% had a genetic link, is it likely that we're missing other genetic links?
I think we're almost certainly missing other genetic links, yes. And I think there's an ongoing effort to identify new mutations that might be predisposing both to male breast cancer, but also to cancers of all sorts, and especially some of my colleagues are very active in looking at this in breast cancer. My colleague Sid Yadav is really a genetic expert in what mutations may be linked to what cancers. And so I usually turn to him for understanding the risks with other sort of less known genetic mutations. I do think there would be some potential that the mutation that you mentioned could be linked, but I would have to defer to him on that. Question about breast cancer in Africa. So yes, there have been some studies, some of them are older, but even in certain countries, there have been rates as high as one study, I believe, I don't know if it was in Gambia, but 15% of all breast cancers were identified in men in that one study. Now, part of that, as I mentioned, is because of lack of mammographic screening in women, so that the overall number in women is lower. But still, part of this is probably due to endemic infections that are causing liver disease.